Namaste. Now I am going to talk about quality of death. You must be wondering that palliative care aims at improving the quality of life of the patient. Then why we are talking about quality of death? This is the only one speciality, palliative care or palliative medicine, which thinks about the death also, which is inevitable in many patients. Hence, it is important to talk about quality of death, as good death is right of each and every patient. Myself, Dr. Geeta Joshi, I am Chief Executive Officer, presently working at Community Oncology Center, Ahmedabad. I had been former director, deputy director and former professor and head of the Department of Palliative Medicine at Gujarat Cancer and Research Institute, Ahmedabad. Define good death. All of us must have never thought about death. We never talk about death. Talking about death is taboo in our society, but one must accept that it is a reality, everybody knows, and it is the reality in patients who are suffering from life limiting illness like cancer, HIV and many other chronic illnesses like heart failure, liver failure or kidney failure. So, when we ask you that define death, it is difficult. It depends on who is defining good death. As a healthcare professional you want to define, the definition is different. As a caregiver it is different, and as a patient it is different. So, definition of good death changes from person to person. Institute of Medicine's definition states that a good death is a one that is free from avoidable distress and suffering for patients, family and caregivers, in general accord with the patients and families' wishes and reasonably consistent with clinical, cultural and ethical standard. So, first and foremost about good death is it should be free from avoidable distress. My definition of good death, it includes pain and symptom management, clear decision making, preparation for death, completion, experience of dignity and respect when the life is ending, closeness to people that care and being at peace. What is your definition? How have you experienced it? Have you ever thought about it? This lecture will give you a scope to think about your death. As per Hughes et al., in this study they examined lung cancer patients' perception of a good death, and 100 lung cancer patients answered open-ended questions about what a good death is. The patients' definitions were diverse and specific. Many of them said dying in my sleep, I wish to die in my sleep. Many said dying quietly, many said dying without pain, and few said dying suddenly. So, the translation of the whole study was people prefer quick, painless and peaceful death. Economist Intelligence Unit in 2011 took up a study in 40 countries, and they tried to find out end of life care services offered in these countries and how best these services are. Among these 40 countries, first 5 were UK, Australia, New Zealand and Ireland, means they have got very good end of life care services and providing good death to the patient. And the India was last in this study, and worst 5 were Mexico, China, Brazil, Uganda and India. This study is taken up almost every second year or 5 years, and the things have not much improved as far as India is concerned. Because in modern medicine, it is death is taken up as a medical failure. See, whenever a person becomes critically ill and taken to hospital, doctors will do each and everything, give cardiac massage and CPR and give oxygen and put him in ICU and on ventilator, insert many tubes and all that, till the patient cannot be revived, the heart cannot be revived. So, medicine's job has become prolong the life at all cost and death as a medical failure. So, as per today's scenario, where do people die? Most of the people die at hospital, 50% of them. 30% die in some or other nursing home and only 20% die at home. There was one study taken up and people were asked, where do you want to die? This study was taken up in Cipla Palliative Care Center in Pune, and their first choice was home, second choice was hospital and nursing home never. So, people do prefer to die at home, but still most of the people die in hospital. Why? Because we are not aware about palliative care, we are not aware about end of life care services, and we are not aware about that home care services provided at home by palliative care team. Many a times it is not available also, but we do not know how we want to die. That is the first question we have to look into. Many a time you must have seen in hospitals, when patient becomes very sick and doctor says patient cannot be revived or survived, they ask the relatives, take patient home. We call it DAMA, that is discharge against medical advice, or LAMA, or sometimes patient's relative take decision that now he is not going to come out of his illness, let us take home, that is left against medical advice. So, this usually happens in ICU setup. So, have you find out, if you are working in a healthcare setup, how many of our patient lives from ICU by DAMA or LAMA, and after they leave, what happens to them? After leaving, they may die on the road or while traveling in ambulance itself, or they, even if they reach home, following that they might have some difficult symptoms, some like agitation or lots of secretion, lots of pain. So, they may die without symptom pain and symptom control, and this gives lots of psychological trauma to relatives and family members around them. So, if a proper end of life care is given to patient and family members, this can be avoided. And see the economy of dying. More than 80% of healthcare spending in India is out of pocket. They are not supported by any insurance scheme or any other scheme. In most of the cases, financial resources are spent on last few days of life. Particularly when patient becomes critical, he is taken to any hospital, any private setup in ICU, and they spend exorbitantly for the life of the patient, and mostly for high end needless medical, and these interventions are not required. If patient is suffering from advanced stage of cancer or any other disease from which he cannot be cured, this intervention going to ICU and spending money is not required. And with no outcome, it is not going to help prolong the life of the patient. And even if it prolongs the life, what type of life it will be? So, maximum amount of money is spent on the investigation which are not required. So, out of pocket spending pushes about 40 to 60 million patients into the poverty every year. Patients sell their belongings and property to for treatment of their dying relative. So, good death has got 6 domains. First of all, physical symptom. A good death should be, if you can say it is good death when patient does not have pain and difficult symptoms when he is dying. Secondly, psychological and cognitive symptoms. A good death is that when patient is not in fear, depression or any other cognitive related symptoms. Third is economic and caregiving needs. Good death is there when you are not spending unnecessarily when the patient is dying. Fourth is social relationship and support. Good death is that when there is a social relation is maintained, patients near and dear ones are around and they are supporting the patient. Fifth is good death is that when there is a spiritual and existential beliefs, patients all spiritual questions are answered, settled, and it gives hope and expectation is fulfilled from the family side, from the relative side. So, this is the 6 domains of the good death. Good death is when patient is suffering from advanced stage of cancer, he knows that I am dying. So, he should accept it, should be able to accept it and cope up with the situation. So, to know when the death is coming and to understand what can be expected. So, this can be, he can solve this problem by talking to doctor, nurses or counselor. To be able to retain control of what happens, he should be involved in the decision making, to be afforded dignity and privacy, to have control over pain relief and symptom control, to have choice and control over where death occurs. If he wishes to die at home, he should be allowed to take to the home when he is at least in good condition or when he is conscious and able to talk to people. To have access to information and expertise of whatever kind is necessary, to have wishes respected and have access to any special needs, and to have control who is present and who shares the end. So, he should be able to express his desire that okay, I want to meet such and such a friend when I am dying, and the friend should be able to reach there. Should be able to live when it is time to go and not to have life prolonged pointlessly, unnecessarily. There is one study taken up by Dilip Jetse et al. And the team uncovered 11 core elements to consider when contemplating a good death. One should always be specific about dying process, religious and spiritual element, emotional well-being, and it should be pain free. So, and they should have treatment preferences, dignity, privacy, family support, quality of life and good relationship with the healthcare provider and before the life completion. So, it is first time then that Indian Association of Palliative Care, it is a medical professionals association, Another association is Indian Association of Critical Care Medicine, again a medical professional. Indian critical care medicine people work in ICU. In palliative care patients, association doctors work with the palliative care patients who are suffering from end stage of many life limiting diseases. These two association, first time they came together and formed a policy, end of life care policy, that when patient is dying, what are the guidelines, how medical professionals should act in this situation, so that patient is given good death and hospital resources are not wasted unnecessarily. That is what about this article is whole about. So, what is end of life care? End of life care is a multidisciplinary team approach towards total care of for patient people with advanced, progressive, incurable or life limiting illness, so that they can live as well as possible before they die. The process of care is not just limited to the person who is dying, but it extends to his or her family and caregiver. And so, by providing good end of life care, the objective is to achieve a good death for any person who is dying, irrespective of the situation, place, diagnosis or duration of illness. Any illness, whether it is kidney failure, liver failure or cancer, patient should has a right for good death. Emphasis on quality of life and quality of death, and acknowledge that good end of life care is a human right and every individual has right to a good, peaceful and dignified death. So, here is the area where the end of life care is given. When patient is diagnosed with a cancer, suppose here is the cancer, then that initially there is a big role of curative treatment, that is radiotherapy, chemotherapy, surgery, and small role of palliative care. So, palliative care should be started right at the diagnosis of the patient. As the course of disease advances, there is a less role of curative treatment and more role of palliative treatment. Then a time comes, now no disease directed treatment is, all treatment is over, cancer is progressing. So, there is no more treatment available and you are sure that now patient is likely to die, and this happens almost 3 to 6 months or sometimes more in few patients, and this period is called end of life care. So, here patient and family should be informed and healthcare worker starts preparing about the end of life care till the death of the patient, and last 2 days terminal illness and so many things are involved. This is a speciality, and after death of the patient relatives are given bereavement support. So, this is the whole diagram of the how palliative care is given and how end of life care is given. If end of life care is given properly communicated with the patient, you can give good death to the patient. So, initially when patient is diagnosed, palliative care is given, but as a complementary care by giving symptom control, support and disease management treatment. Patient is undergoing chemotherapy, radiotherapy, and if disease progresses, then patient goes into hospice for only symptom control and supportive care. Now, disease management is not present over here, and in hospice care comes the end of life care, and here patient is given only symptom control and he is prepared for good death. End of life care services is a teamwork. Family should be prepared, educated and feel supported. Caregivers should be involved and empowered to provide end of life care. Healthcare providers should be accepting and anticipating that patient is dying and willing to provide end of life care. Achieve good control of pain and symptom control, this is most important, and it can be done by providing good palliative care. And the talk is initiated with firstly with the family or caregiver, that now patient is going to die, where you want to take him, where he prefers to die, what are the rituals you want to follow, whom he wants to meet before dying, all such communication takes place. And this is done in very good way, so that healthcare providers should feel comfortable, confident, and should be able to foster a sense of teamwork. For providing good end of life care, all institutions should have a policy, a space, proper staff who are trained staff and who has received training in this communication and for providing palliative care. And there should be proper documents also available. After each communication, healthcare provider writes down in the case sheet, take the consent of the patient or caregiver, and such records are maintained. Sometimes this is not possible because many a times physicians, paramedics are not trained about the end of life care, they do not have knowledge, they have fear that a patient will feel bad, relatives will feel bad. There are many policy and legal hurdles, and there are social barriers, as because of social, cultural and norm, people do not accept the death, they do not talk about the death, and patient and family also, they always look for cure, they are in phase of denial that patient is dying. These are the guidelines given by the our two association who have worked together and formed a guideline, that first of all physician objective and subjective assessment is done by physician, that now definitely medical treatment is futile and dying process has started, and this consensus is achieved among all caregivers, and this is talked to patient, discuss and the communication of modalities of end of life care with the family, they take decision, and all this is they take decision about not putting the patient on ventilator, not getting him admitted in ICU, not giving him oxygen, not to resuscitate, all such withholding and withdrawing life support is implemented, talked to relative, and consent is taken on the paper. At all the time, one has to be very effective and compassionate palliative care should be continued to the patient, and appropriate support should be given to the family, and after death bereavement support to the family and caregiver. So, this is the guideline of the end of life care process. Advantage is that it is a continuum of care throughout the disease journey, patient keeps on receiving palliative care and pain and symptom management. So, end of life care is also continuum of care. So, patient and there will not be sudden discharge of the patient and sudden leaving from the ICU. So, this patient ICU beds are spared for patient who need them most. So, there will be more turnover the patient, more opportunity to treat more number, and image of the hospital and healthcare is improved through word of mouth. In closing, I would like to say you have the perfect opportunity to have good death dialogue, education about end of life and goals of care is within your scope of practice, and get involved. Education is necessary, communication is necessary, and with more research in this subject we can make a difference. Thank you very much.